Okay, thank you very much, Miriam, for the introduction. And I'm really glad that you gave your personal story, because that is the ultimate message that I want to give. Just quickly, you've already given the, I guess, some of my disclosures, which I'm supposed to do. So yes, I am the medical director of Renaissance. Renaissance isn't paying me to do this, but that is my job. I am the director of the food addiction inpatient program, which is a 30-day program, and the 5-day outpatient program. I guess I have a vested interest in clinicians being aware of that program. Whoops, I'm sorry. And I have my book, which is Food Junkies, which, by the way, because you are all who are watching this opinion leaders, in other words, you can influence people to read the book, I'm more than happy to send you a complimentary copy, providing you use it, to tell people about it, just because I want the message out there. And that's my disclosure. Now, I'm supposed to tell you the learning objectives, and hopefully, you know, this is normally a talk that could easily be 2 to 3 hours, and because I suspect that a lot of this information is already familiar to you, I can move through some stuff fairly quickly so that we can get most of the information done within the hour. But my goal is to talk about the hormonal and neurochemical drivers of appetite and satiety, half of which you know. I'm just going to show you how the connection is. I'm sorry, I realize I can't do that. I'm going to identify disorders when these components are hijacked by sugar and refined foods. I want to discuss the diagnosis and clinical syndrome of food addiction itself as an entity, differentiate that from eating disorders, and then look at using the addiction model as a treatment paradigm that gives us a whole bag of new tricks beyond the stuff that we normally have. So even if you don't buy the actual concept, which I hope to convince you of, there's a lot of tools that are otherwise not available that you can use, and I'm going to show you some of those tools, mainly the biggest one being cessation of trigger foods. Okay, so let me start by saying everybody's familiar with processed food, and if we didn't have this, we wouldn't be having this conversation. Because of that, the whole, whoops, I'm sorry, I have to be careful with what I'm doing here. Because of that, the whole definition, you know, is it food addiction? Is it sugar addiction? Is it processed food addiction? Is it refined carb addiction? We don't know. It is something that we're still debating, but we could be debating this one for a long time. So generally people just use the word food addiction, but you'll find that some people are being more specific and saying processed food or refined carbs, because it basically starts with carbs. But then one of the things that I want to suggest is that in later stages of carb addiction or eating addictive foods, an entity called addiction, food addiction, develops, and that expands beyond just carbs. It can include fats, sugars, fats and proteins, and just eating behavior itself. So it can actually expand beyond this specific food, just like addiction can cross-sensitized to other things. And in fact, sugar/food addiction can actually be a gateway for other drugs and vice versa. So that's why I'm partial to the term food addiction. But anyway, just so you know, the jury is out on that one. We're still debating that one, like we're debating almost everything else in this field. Okay, so the problem as it is, here's where I know I'm preaching to the converted. I mean, you are physicians that are dealing a lot with bariatric or obese patients, and so we already know that 2/3 of the Western world is either overweight or obese. I don't want to dwell on that, just that's the problem, and it's based on the understanding of the body mass index, which is the problem, and that in the clinics where we work, that generally speaking, a person comes in with all of these conditions which are related to either just obesity or metabolic syndrome, which is not necessarily related to obesity, but it ends up being a lot of overlap, and that people will either come into a clinic and talk about their addiction or, usually compulsive eating, or their mood, and then have all these other conditions, including obesity, and we get stuck treating those conditions and then just saying, well, I don't know what to do, just lose weight, which of course hasn't worked. So the sort of paradigm of medical treatment today is certainly in bariatric medicine that I'm aware of, is we've got this these lists of conditions which include mood, although I don't see a lot of attention paid to that, but when it is, that's acknowledged. And let's treat these things. My understanding is that there used to be advice to lose weight and some of these problems will go away, but now my sense is that there's a kind of awareness of shaming, fat shaming, so that maybe the suggestion of... Okay. Sorry, are we good? Yeah. I'm going to continue on, or not? Yeah, okay. So that maybe... I forgot where I was here. So that clinical work is that there might be some talk about weight loss, but my sense is, like in 2020, that there's less of that because there's an awareness that what's the point? The person's not going to lose weight anyway, or when they do, they gain it back. So let's just treat these conditions and, as much as possible, maybe find medications to deal with the weight and, I guess, generally speaking, push for bariatric surgery. Anyway, if a person does say, look, I want to deal with my eating behavior, here's the paradigm that I would like to work from. There's 3 ways that we can look at compulsive overeating. The way that, generally speaking, clinicians have been working, which is we're normal overeaters but have an endocrine disruption because of the foods, and we can work with that. Not very successfully, but that's sort of where we've been working, and I'm going to talk more about that. Actually, the first half of my talk will be really talking about that. We can be aware that there may be another component, a psychological component, called eating disorder. That's not, I mean, the people who deal with the endocrine model of normal overeaters that have been sort of derailed by our food industry tend to be medical clinicians, endocrinologists, family doctors, dietitians, and then this second model, the eating disorder, tends to be the psychologists, not so much looking at this sort of physical model, but the what's the psychological dynamics behind it. Was there past trauma? Was there sexual history of trauma? And that maybe the food, maybe the food is a way to control and manage a psychological disruption, and so that's what we should be doing. And those seem to be the 2 medical frameworks for dealing with disordered eating. And then this concept of food addiction, which has been around, for those of you who don't know this, since the 1960s. OA, or Overeaters Anonymous, started, I think, in 1961. In the public realm, in the non-clinical world, there's been a lot of talk about food addiction, but it's never really moved into the realm of clinical acceptance until now. And really now, I guess really since 2008, when the ASAM, the American Society of Addiction Medicine, published their first journal on addiction and food, and they're the ones that brought in Nicole Lavina with her studies of rats, PET scans in rats that choose cocaine choose sucrose or even saccharin over cocaine. And so when we started to get that kind of research, then there's been more and more clinical, but still, it's still not acceptable as a diet. It hasn't reached the DSM-5. In fact, the DSM-5, which all of you know, is a committee of many specialists who argue their case for a new a disorder, and binge eating disorder was approved, and the food addiction components or people, advocates were there also with their placards saying, please listen to us, but they were unable to show the difference between binge eating and food addiction, and were asked to come back when they could show that difference. Very hard to do if we can't acknowledge the condition. Anyway, so I don't know if I want to say more. So the people who are dealing with food addiction tend to be, like I said, the public, social workers, the addiction counselors, not very many medical clinicians, so they haven't managed to get, we don't read we don't read each other's literature, except that we're starting to a little bit now. Okay. So my job today is to introduce this model, and what I really want to show is that these two models I'm not going to argue against them. I'm going to say they are sound, they're good, let's work with them, but here is an underlying model that we want to include, as it were, offered on the plate with the other options. And when we have all three working together, unfortunately they're usually in a muddy mess, then we can have a better chance of success, both in understanding and in treatment. I always like to show this picture just to, again, I know I'm speaking to people who know this already. This is the complexity of satiety and appetite drives, which the blue is the sort of endocrine model, and becoming ever more complex as we learn more about more hormones and more components of appetite. And then this red underneath is the addiction piece. They actually work very nicely together, but this is the one that's been neglected. But they both work together. I want to show you this to show the complexity and also how important this piece can be to aiding and understanding the whole picture. Okay, so now what I want to do is take a couple of minutes to show what we mean by the endocrine model, and then how that fits with the addiction model. So, generally speaking, I guess I want to say the medical model so far has been to use this endocrine hormonal model, and with the exception of the people, probably many of whom are listening here, who have a better understanding about the hyperinsulinemia and the whole idea of it's not actually about the calories, which I think that you guys are a select group. Generally speaking, the medical model is still calories in, calories out. So in other words, how many calories we eat and how many we burn off will determine our weight. Which, by the way, I want to say has truth to it. It's just it's not enough. And to understand that, I've tried to make this as simple as possible, because this is going to be a very complicated talk, to show that the hormone drives of appetite and satiety that I want to look at today, which I think covers a very good understanding of the whole picture, is ghrelin and leptin and insulin and cortisol, and then how they link with the reward pathway. This is the addiction framework. So my sense is that the bariatric world focuses much here, and just going to wait. Okay, and the addiction pathway is, we look at this part here, and I want to show how the two of them work together. So, without saying too much, because I want to say that, we know there's a feedback loop with leptin and ghrelin and insulin, and I just want to touch a little bit on that. But I'd like to show this slide first, before I talk about leptin and ghrelin. That in the work that I do, which is the addiction world, we talk about that concept of serenity and sobriety. And, food serenity and food sobriety is when you have a hunger scale, which is like from starving, extremely hungry, to so full that you're sick, that food serenity should be around the 3 or 4 line where you feel hunger, appropriate hunger, and you feel full, so 3 to a 4 to a 7. And that is the concept of what we want of a food sobriety, food serenity. You want to be hungry enough that you enjoy your food, and then you want to be full enough but not overly full. And I think that if we did not eat the foods of today, which I think are extremely toxic, and I'm talking about refined foods, we would probably happily live in this world of 3 to 7, because, and then it's the extremes here that is what our food industry has put us into, which, by the way, is still not addiction. So even in this part of the talk, the first part where I'm talking about the hormonal piece, where addictiveness is introduced, it's still not food addiction. That's a second piece that I'll talk about later, which means for people who are not convinced that food addiction exists, but are aware that their foods can be addictive, like it's hard to put down a couple of chips when you've started the bag, but it doesn't mean you're a food addict. Weight Watchers and Jenny Craig and just quitting and being on a diet may well work if you stay within a fairly non-toxic food environment. But the more you get into the processed food thing, where the deliberation to make foods addictive, we move into here, and then the more that happens, then the more ultimately a food addiction syndrome can develop. But so anyway, that's what I'm saying there. This realm of between 3 and 7 or 8, I think, is achieved by the ghrelin-leptin feedback loop. So, we have the stomach that's emptying. As it empties, ghrelin is released and appetite is increased. So that's the growling stomach, as it were. And as you eat, leptin is, over the course of 20 minutes, and that's why we eat slowly, is released to give that feeling of fullness through neuropeptide Y, or just the feeling of a constrained stomach, so that there is a physiological sense that's made with the ghrelin-leptin loop, where we have ghrelin, which increases appetite, you eat, and then leptin is kicked in and you are full. And it's a perfect system if we're eating normal foods, because it takes about 20 minutes to process those foods. And, appropriate hunger, the stomach growling type, is a 3 or a 4. It's not going to be a 1 or a 2, that ravished hunger, which I believe is actually when insulin is kicked in. So the 3 to 4 is when we're just working with this, and this works really well in a good food environment. In other words, a non-processed food, where food is digested slowly, the glycemic index, things are between, not really higher than 60 or 70, certainly not in the 80, 90 range, where this gets askew. So these are, I'm going to say it's the food sobriety piece. And just to introduce the idea here of, I've just mentioned these two, ghrelin, leptin, and how they relate to this. So we know, I don't know if I'm just going to say, we know that ghrelin, which is the hunger hormone, will initiate dopamine, and that makes good physiological sense. When you're hungry, you start to think about food. And if you're a 4 if you think about that hunger, here we just have a look. If we think about this, the moment you start thinking about food, you're a 4 or something like that, you're gonna start thinking about food, and dopamine gets brought in, because it's dopamine is our neurochemical of anticipation. It's our neurochemical of desire, of want. I don't have the substance, but I want it. And the hungrier I get, from maybe a 5 to a 4 to a 3 to a 2, the more mental landscape is taken up by dopamine in the aspect of I'm starting to think about foods. And if I've been waiting for too long, and I'm getting very hungry, not only does my essentially becomes an obsession. Not only do my thoughts start to think about food all the time and more urgent, but also now they're becoming energy dense foods like high sugar and high carb because my sugars are going down. And that to me is a sign that insulin is getting kicked in. But if we're eating normal foods, not processed foods, usually this is enough to say, okay, it's time to eat. Leptin is a curb on dopamine, so that after I've been to the buffet at a restaurant, dopamine is the neurochemical of desire, so new things always interest me. If I'm eating off the menu, or I've sat down after a full plate of something at a buffet, I'm full and I'm good, and leptin is full. It's satiating, and I don't want any more. But if I get up and have a look at more food, suddenly I haven't tried that, and now I've got hunger that I didn't have before. I was actually full a minute ago, and now the dopamine has overridden my fullness and is kicked in. If I can say here, this to me is the buffet example of, I'm full, can't possibly eat anymore, and then you walk by the dessert tray, and all of a sudden you can eat again, is a really good indication of how I think that as much as we understand this hormonal piece and work with it with medications and with all sorts of manipulations, if we don't pay attention to this, I think this is actually a more powerful contributor to disordered eating, because most food addicts, they are bursting with pain. They are so full, and yet they still want more food. It has nothing to do with hunger, and that's why I think the addiction paradigm is so important in understanding this whole process. So, okay, but it's not going to get that bad if we're eating processed food, because, I may not have tried that Brussels sprout dish or, the new crabs or something but, so I might have a little bit. But if I eat something that's processed, like I said, this will dominate. So that's leptin, ghrelin, and there's a dopamine connection. And just to show you some research, I yellowed out the stuff that I thought was interesting. Evidence suggests that peripheral hormones like leptin and ghrelin are involved in the anticipation and motivation of food, and may be partially mediated through their effects on the VTA. And so this effect of the VTA, that's our hormonal, our motivational center. This has nothing to do with hunger. This has got to do with motivation and wanting. I don't know what I want, but I want. The wanting itself is a part of this reward pathway that I just mentioned, and actually has nothing to do with food, other than that leptin and ghrelin are hooked into it. And here again, ghrelin infusions into the VTA increase food intake dramatically and stimulate dopamine release. So there's a direct connection. And finally, neuropeptide Y, how does that fit in? Because that makes you want to eat more. There is also a mesolimbic dopamine circuitry that increases motivational behavior towards food. Not clear how it works, according to this paper in 2017, but there's an awareness in the research that there's a connection between the hormones and the reward circuitry. So if people say this doesn't exist, it's there in the research. We just have to start connecting the dots. And I think that we can if we continue to look. So that's ghrelin, leptin, and dopamine. Now, if we are living in a processed food world where we start getting a problem with our hormones, like, for example, insulin resistance, which we'll talk about in a minute, and leptin resistance. Well, if there's leptin resistance, then there's no brake on the dopamine, and so we've got a problem right there. I actually think that metabolic syndrome, which includes leptin resistance, probably, this is just Vera making I guess a thought experiment, if you want to call it that. I wouldn't be surprised if the level of metabolic syndrome and conditions like this, like insulin resistance, leptin resistance, probably we see a similar disarray with addiction as well, like a food addiction. That there's a parallel process. That's what I'm trying to say. But that's just me thinking that. Fructose, which we know, I mean, this is, you know, the processed food industry, high fructose corn syrup, et cetera, so much of our processed food includes this, just to show that fructose suppresses leptin, so therefore the job of leptin is to suppress the dopamine, hunger is increased, and therefore dopamine is the I want, even if I'm not hungry. Well, here I am still hungry, and I also want. Fructose doesn't allow ghrelin to be suppressed when it finally should be. It doesn't inhibit it, so hunger continues. Similarly, ghrelin, if it's not inhibited, it's the link to dopamine, and it also increases insulin, and that too makes you hungry, increases desire. So I want to talk about insulin. So I've talked about ghrelin, talked about leptin and dopamine, that connection, and now if we move into insulin, which I think is the most powerful hunger hormone that exists, and my training, I would be interested to know what you think. My training has always been that, or my understanding, that when you eat, insulin responds because you're eating, and presumably eating sugar or some kind of carbohydrate, and the insulin mounts to take care of that. But there's even a pre-anticipatory rise even before you start to eat, which is also dopamine, because dopamine dopamine does many things to the body. Just think about gambling. There's not a thing that you put into your body with gambling, and yet it has an impact on the whole addiction reward circuitry. Anyway, when insulin is introduced into the bloodstream, and you don't have the amount of sugar, or you can't deal with it to mop it up, or you've got so much insulin and the sugar can't be used, eventually what ends up happening is if the sugar, you're going to have hyperinsulinemia, or you'll have a sugar crash where the sugar is going down, which is a life-threatening event, especially if you're a diabetic or even hypoglycemic, becoming extremely grumpy, and that will corral in your stress response, which will make you want more sugar. So insulin is, if we can go back to our picture of, I'm going to just show you here. Ghrelin, leptin, I think, is here in this 3 to 7 range, and when we're at the extreme hungry range, which is probably because the sugar is going down because you're on a diet and you're not eating, or you've eaten so much food and now you're crashing, because so much refined sugars that now you're crashing, you're going to be in an extremely hungry mode and then eat to this point here because you need to. I mean, it becomes a stress response. It becomes essentially a life-threatening, because your body doesn't know that it's just because you had too many refined carbs. It just knows sugar is down, and I better eat a lot to compensate. So I would like to suggest that a lot of eating disorders are a compensatory response to the food environment that we have today, much of which will put people into an hyperinsulinemic or hypoglycemic state and bring people into this realm here. And we know with insulin, just to go back now, as I was saying, the connection with dopamine, there is a very strong connection with insulin and dopamine. Just like there is with ghrelin and leptin, there is with dopamine. It has to be, because if I'm starving, and I'm starving to the point where my sugars are going down to the point of potential death, I'm going to be thinking about sugar all the time, food all the time, and it'll be sugar, it'll be the stuff like that. So we know that the more insulin, the more dopamine is released. Here's another piece here, and I just want to say here, I wasn't able to highlight this one, but we believe that there's a role for insulin reward pathway, suggests that rodents, presumably people, may choose to consume high carb meals that release more insulin because that's going to give you more dopamine. Now, if I can just stop here for a second and just say that I think that a person who is anorexic, who is starving, they are so hungry that they're on that curve of 0 to 1 on the hunger scale. Their dopamine is raging because all they can think about is food. All they can think about is fantasies of food. They're not eating the food, but they're 24/7 thinking about it. It's become an obsession. I really think that you could make a case that anorexia is a version of food addiction as well, just on one end. Okay, so that's insulin. What have I got here? These experiments show that elevations in insulin produce increased hunger, heightened perceived pleasantness of sweet taste, and increased food intake, which would make sense because the body wants to increase food. Cortisol or stress response only makes this worse. So, by the way, if you have insulin resistance, it just makes it makes the whole thing worse. You've got a hyperinsulinemia and high dopamine, and cortisol. Like I said, it makes it worse. And through various mechanisms, it increases insulin resistance, so sugar availability. It stimulates appetite so that you get more sugar, and then if you're not actually eating it, you'll make it. So it just makes it worse. So that's the hunger scale. I know that we've talked about a lot of doctors are very interested in the effect of the metabolic syndrome, and how what we essentially have is, the visceral fat. You have all that sugar that you're unable to mop up or deal with, so it has to get parked here. And of course causes all sorts of problems in the future. Maybe not right now. It's probably a compensation to take care of the immediate danger of problems with vision and kidneys and whatnot. The microvasculature. Store it here for a while until it actually kills you in 10 years or 5 years or something like that. Dr. Lustig, if you have not read his work, you definitely should. He argues that, and he talks a lot about fructose and the concept of insulin. He says that fructose is basically alcohol without the buzz, because we're talking about addiction here. And then at another paper, he actually seems to admit that, yes, there might be a buzz. But I think the important thing here that I want to say is that by stimulating the hedonic pathway of the brain, which is the reward pathway, indirectly and directly, fructose creates habituation and possible dependence, paralleling alcohol. So how does that actually happen? That's the piece I want to talk about. So here we go. This is a hypoglycemic creature who has crashed. Okay, now. So what I've talked about so far is the hormonal drivers of satiety, of insulin and ghrelin, leptin, and their link to dopamine, and how foods can be addictive because if you, through manipulating foods by giving extra sugar, which leads to dopamine surges, or just by manipulating the hormones in the way that I've described, you'll get addictive eating. But if you eat properly, you go on the keto diet or the paleo diet or just a real food diet, you may actually very well correct the problem. And what I would like to say is that if you stay in that toxic environment, you may actually move to another phase where there is no going back. And I want to talk about that too. So I hope I've explained this to some degree, and now I want to move into this piece here, this missing link, so that I get to say there is a food addiction. It's not just addictive eating. And this is the piece that people really struggle with. It's like, no, you can't be addicted to food. And of course, what we mean is processed food, but ultimately it might even mean other food that's not processed, if the syndrome has developed far enough. So that's what I want to talk about. So here's the addictive piece, and then if you're into this stage here, something else is happening, and that's what I want to look at. So now, I hope that what I've done so far, I've covered ground that you're fairly familiar with. Now what I want to do is give you a super dense, quick discussion about addiction. Hopefully it's going to be not too dense. But anyway, the next 4 slides are like, this is addiction. If you get this, you understand the whole concept of addiction. So, we're looking at this pathway in the brain, the limbic pathway, the motivational, instinctual pathway of the brain. There's 2 key areas that we're interested in: the amygdala, I like to say that that's the panic button, and the nucleus accumbens, which is the pleasure button, the motivational piece where dopamine does its work. Anyway, that's the piece here that we're looking at. Specifically, the nucleus accumbens. When food comes in, it's taken in the ventral tegmental area. The neurons fire here, basically get a dopamine response, and then seconds later, the prefrontal cortex is alerted that something has happened. So this piece of the brain here, which is the instinctual, motivational part, is where all of the magic happens, as it were. And in the addiction world, we see that alcohol, heroin, cocaine, nicotine, food, sex, gambling, all of them work on the same circuitry. When you read about stuff that says, oh, PET scans show the same things that light up as cocaine, as heroin, as nicotine, that's what we're talking about, is this. It's lighting up this part of the brain here. And if I can just take a moment to say that these are all hijackers of this system that has been put into place to motivate us to do things. It's our motivational system to do things that keep us alive. I don't need heroin and cocaine to be alive. These substances have hijacked a system already in place. And food is one of those systems already in place. And when we talk about, and please believe me when I say that I have people who are crack addicts, alcoholics are out on the street, to the point where they don't pay their rent anymore, like basically low bottom, or crystal meth addicts who are, always using. When they finally stop, they will say sugar was harder to quit than their drug, often because they've used sugar as part of their way to stop that other substance. But I think it's because we're using a system that's already in place. I don't need to hijack with sugar because it's already in place. I just need to give more of it and manipulate. I can make anything addictive, anything, like gambling, like sex, like love. If I give a person a lot very quickly and more than the norm. And that's what we do with food. We eat food, processed food, which gives us far too much fructose, glucose than our brain needs, and far quickly because we're not digesting it. We're just slurping it down, or in the mush of a chocolate bar or something like that. So it very nicely snuggles in and does all the check marks that make something addictive without even having to hijack. That's why I think it's the stickiest and the hardest to quit. At least that's my thinking about that, and it just seems to be so true clinically. So when we look at what's happening, what's the backstory here, it's the neurochemistry. Primarily, we are interested in dopamine. But there are other neurochemicals that are happy chemicals that operate in this nucleus accumbens area. But the dopamine is the key one that we studied. It's the matriarch or patriarch of addiction, as it were. It's the want, the anticipation. And I can, when I do cocaine, when I do crystal meth, when I smoke a cigarette, when I engage in anticipatory behavior, like gambling, I'm focusing on the want. And when I look at the buffet and I go, oh my God, I haven't tried that, I'm going to try that, suddenly this takes over. So that's the dopamine, the I want. Serotonin is another neurochemical that is a satisfactory. It's the one that in the addiction world, we use the language of addiction, gratitude and connection. The opposite of addiction, which is a dopamine alteration, is connection. The opposite of addiction is connection. If you've heard that phrase, connection is the I have. I don't need because I've got. So I don't need to want because I have. And they work very nicely together as like the ghrelin leptin thing, as counteract each other. But if you have too much dopamine, you may feel like you have, but the dopamine will overpower. And the endorphin is a very important player two, it's our neurochemical that makes me numb from pain, either emotional or physical pain. So these can all be enhanced, and in fact are with alcohol and sugar. And if I can get more quickly, I've got something that's potentially addictive. So that's the neurochemicals. And just want to say something about, because this is a mini lecture on addiction itself. Remember I said amplitude, how much? If I can get more, and speed, if I can get it fast, then I get into something that's addictive. So dopamine is my neurochemical of desire. It's the thing that gets me through the day. I want to know what people are thinking right now. I want to know what the show is going to be later on. I want to know stuff, and that gets me through the day. And if I don't want to know, I'm depressed and I don't care, and that's not good. In order to make the effort to motivate myself to eat food or have sex or have companionship or to get housing, I have to get a little bit extra for my efforts. And that's why we say addiction and recovery is a selfish program. It's all about me and wanting something. And normally we live, it's like that 3 to 5 ghrelin leptin the food continuum. We normally live in this realm here. This was something that was done with rats, actually, but it's the comparison that's interesting. And this chart is one that we use all the time in the addiction world. So normal is sort of between, I guess, 50 and 200. And if I've had a really great day, I'm in the 150s maybe. And if I've had a low day, it might be 80. But mostly I can handle this. And my mindfulness meditation, cognitive therapy, all the tools of normal good life will work well in this realm. If I take a substance which hijacks the dopamine, like nicotine, like opiate, like alcohol, I'm going to get more, some amplitude, than I want. And then my dopamine will be higher than my ability to be satisfied and my ability to say no. So as much as I am saying no, I don't want to do this because it'll affect my day tomorrow or my money, my poverty, whatever. The drive to use despite for the dopamine will overpower. Cocaine and crystal meth, even more often because of speed of intake. I can smoke, I can inject these. Nicotine, which may not have the same amplitude, it's because we smoke it that it has the power that it has. If we could smoke sugar, we would, sugar, which actually is probably in this realm here, we would be in great trouble. And indeed, with vaping, I think we are in great trouble. I'm not a fan of vaping because I see that people are smoking sugar, not good. Okay, so that's another piece for the addiction thing. Now, how do I know that given this phenomenon of the dopamine and the endorphin and this amplitude and whatever, how do I know that I'm actually in trouble? If I find that dopamine surge, that desire overpowers, then I'm in trouble. And we have used the concept of the DSM-5 addiction. There are now 11 criteria from 0 to 11, and anything up to 3 is mild, and then from 9 onwards is severe. It's a continuum that we're measuring these kind of dimensions, and wherever you fit in that, that's going to be your level of addiction. So if you know that you want to, so it's the ABCDEs of addiction: abstain, behavior, craving, D, diminish, E, emotional. So you can see it's the ABCDEs of addiction. And this is the American Society of Addiction Medicine has proposed. This is just one back pocket tool that you can use. You can do the DSM-5 addiction thing, but it's measuring the same kind of thing. So this is like, I guess it's like the cage where you have a few questions that you can just quickly think. So impairment of behavioral control. Can you control the amount? So what we're measuring here is the dopamine surge. I may be able to, I like something, therefore I want it again. That's how we are. That's how this part of our brain is. It registers, here's a potential environmental positive of some kind of a pleasure, therefore survival impact. So therefore I'm going to want to do it again. And if I find that I can't control the amount, then that's one check mark. If that craving gets bigger and bigger, which happens, especially if I'm outside of the realm, we go back to here, of this. It likely won't happen in the normal realm, but if I'm drinking alcohol or doing an opiate and I'm up here, we have a term that's called tolerance or dependence, where the receptors downregulate so that what is actually a 400 will feel like a 200. Because the brain, as much as we may like the pleasure of the experience, the brain doesn't want that for very long. So it will eventually downregulate so that the new becomes the old, or however that works. Anyway, basically you become tolerant, and you become more and more tolerant. So as you become more and more tolerant, the craving, because you're trying to chase a high that you're not getting, so you start to develop more mental real estate to getting that. So cravings ultimately become obsession. And as you are in that obsessive realm of, I need 4 to feel like just 2, impairment inevitably happens, because it may not happen at this realm of 0 to 200, maybe 1 drink a day, but if I'm up to, or 1 apple or 2 apples a day, but if I'm here at the 2-4 a day, or 12 beer a day, or a number of chocolate bars a day, there's a downregulation that's occurred, and I can know. Wait a second, where am I here? I'm starting to get impairment because of the excess amount of alcohol or food or whatever, like the hyperinsulinemia or whatever else might happen. Impairment happens, so that's another check mark. I can't control it anymore. I'm obsessing, that's a check mark. Now there are problems that are happening, impairments, that's a check mark. If I then want to stop because now I've got diabetes and I have to stop and I can't, or I don't have any money, so where am I going to get the money to buy my next hit of crack? I'm still going to figure it out somehow. I cannot stop no matter how much I try to, so that's another check mark. And then what we seem to have is a period of denial. It's almost as if, this is very typical with addiction, I actually think this is a societal response too, with our denial of this whole thing. It's almost like a delusion that this is not so bad, an ability to dismiss, so that the alcoholic will say, and they have said to me, yes, I see I have cirrhosis, but really, what's one more day going to do? I'll have another drink and I'll quit tomorrow. And, of course, we know that they can have, hypertensive crisis or a stroke that night. I mean, it can make a big difference, but in their mind, it's almost like a delusionary piece that's fairly endemic in the addiction paradigm. And when people get clean after a number of months or years, they'll actually see in the past, oh my God, I was really out there and I didn't see it. So denial is a piece. So if you can do all those check marks, that's what the 20 questions of food addiction or AA or whatever, or the DSM-5 are essentially trying to capture. I want to get going here. The pull of addiction is you can stop, but remember I mentioned about I was talking about, oh my gosh, I'm getting lost here, the concept of dependence, tolerance. If 4 is really feels like 2, initially in early stage, the 3, now it's 4, I'm going to need 6 to feel good. That's often the initial reinforcement, because it's basically, addiction is an operant learning conditioning model. So that's great. But with tolerance, eventually what happens is if I don't have the 4, then I will feel really bad. So Me, Vera, I don't drink at all. If I don't have a drink, it doesn't matter. I don't need a drink. And if I were to only do one a day, and I had no previous problems with alcohol, then it wouldn't hurt because I'm still within that normal realm. But if I'm at the 4 or 5, and I've developed a tolerance, not having the 4 or 5 is going to be very difficult. And so my desire to use is both positive and also negative reinforcement. I'm doing it just to feel normal, not to feel bad. So we have the dopamine, and we have the stress response, which is tremendous. I mean, it's an instinctual, life. It's a survival mechanism. And addicts will say, I need this drink as if I were going to die. And for any of you who have struggled with food, in the middle of an episode, you'll feel like, if I don't get that food, I will die. And of course you're not going to die, but that's exactly how it feels. And that's a real indication of addiction. Now, I don't know if you've heard this, but in the addiction world, this is the last slide I want to show about addiction. There's a term that you hear often, one drink is too many and 1,000 is not enough. Well, if you've developed a tolerance, 1,000 won't, I mean, the concept is a couple is not enough. In order to feel the effect, you need a lot because you have to get past that tolerance level. But why is it that one drink or one bite, one something? And here's the piece that's so important with the importance of recognizing that this is an addiction, is that there is probably some kind of kindling behavior, like seizures. Once you've started a process, I'm not talking about the very beginning, but the abusive binge-like eating, drinking, and then repeated withdrawal, in other words, trying to quit, and eventually moves into a dimension where you get a hypersensitivity to both the withdrawal and to the susceptibility. Like here it says here, altered subjective perception of the effects. So that there's almost an increased sensitivity, even with the downregulation. It might just be a memory. I don't know what it is, but I see it happening all the time, that the more a person is trying to quit, the harder it gets to quit. So anyway, what all of this is to show that addiction is a phenomena, and I've just given you the sort of many pieces of that. Dopamine, endorphins, serotonin give a lot very quickly, and then you move into tolerance and then withdrawal, and you end up moving into a paradigm which is basically you can't win. You can't. It's like you're between a rock and a hard place. And what we say in the addiction world is you can't use and you can't not use. And when you're in that place of I can't use because of the impairments and I can't not use because the withdrawal is too daunting, then you're in trouble. That's addiction. And let's just look at some of the foods. I mentioned dopamine. I mentioned the 3 of them. We know that alcohol enhances dopamine, serotonin, and endorphin. And not a surprise because, I mean, what is sugar but, alcohol, but fructose, fermented fructose. So we've got sugar doing the same thing. And it's not been unusual for me to see that an alcoholic really moves nicely into using sugar as a way to subdue their alcoholism. And white starches, of course, too. And I think I don't want to spend too much time on this. These are not necessarily addictions, but warm milk increases the tryptophan and therefore serotonin, and pasta and potatoes and bananas and turkey all make you sleepy and that kind of nice, comfortable feeling. And the endorphins will give you a kind of glazed feeling. I like to think of it as dopamine in terms of food. It's like the candy that you eat. You get that kind of buzzy feeling. Serotonin are like the chips and the I don't know, I guess the savory stuff. And endorphins, that's like the tub of Haagen-Dazs ice cream at the end of a day when you just glaze over or eat a lot of bread or something like that. Anyway, there you go. This is just to show that the different amounts of sugar and therefore potential dopamine response. And the studies like Nicole Levine which show that the part of the brain lights up. This is the kind of stuff that we're talking about. The higher the amount of excess refined sugar, so it's going to the brain quickly, and excessive amounts like this. I mean, these are just shoo-ins for bursts of dopamine. And we have some research that shows this, and I'd just like to show here, obese subjects, like other substance users, have decreased dopamine receptors. So just like, here's the deregulation, downregulation of dopamine, just like the control subject, the methamphetamine, which is also dopamine, it is dopamine. The dopamine becomes blunted or downregulated. We see the same thing with obesity. We're making the assumption that that's because of the foods that person's eaten. It could be genetic too, because I think that that's very likely too. There's a lot of discussion about the genetics of addiction, so a person could come to the table, as it were, with already a blunted response. See addiction in this context as an impaired dopamine response. It's almost like you've got insulin resistance, leptin resistance, and dopamine resistance. I mean, I think that and I do think they probably work in tandem and parallel with each other. I'm just taking that step further out, but that's been my experience clinically. We see that the more a person becomes obese, the less dopamine receptors. I mean, there's a blunting response here. What the cause is, I don't know. Is it epigenetics, like exposure to the food environment, or doing something with somebody who's already got a genetic predisposition, or is it just pure environmental? These are questions to ask, but we know that there's a connection here. I think I'm just going to jump ahead here. We know that when people take naloxone, which is an anti-opiate, we use naloxone to help somebody or to get off of an opiate, also to stop drinking alcohol. That's called Revia in that case, or we're now using it for food. So that's why, because it will cause a food sugar cessation. And anyway, you'll see basically a withdrawal pattern with naloxone, just like we will with food deprivation. I'm just going to jump ahead because I think we're getting low on time. There's been some work on things like milk protein having some opiate casomorphine in it that might play a role as well, and wheat as well. So that there's, I'm focusing mainly on the sugar, but there's more research that looks at the addictive nature of other foods, not just sugar. This is a study actually that Nicole Avina did. She's not the only one, but she's a big name in this field. And she did a study looking at the addictive nature of 20 foods, specific foods, and found, not surprising, that chocolate was number one, and ice cream and French fries and pizza and cookie and chips and cake and popcorn and cheeseburger and muffin, the top 10. And at the bottom of the list was broccoli, not surprising, and carrots and salmon. So not surprising. I mean, I don't see steak there, but it could have. I probably would have been right at the bottom. Anyway, so I already talked about that. Let's see, where am I going here now? Yeah, I think I was going to use it. Okay, so talked about the hormonal piece. I've talked about the concept of addiction and how specific foods can be addictive. And now, how do you know if you're a food addict? Well, I explained some of the actual criteria of that, but just want to spend a bit of time looking at this. This is the regular diet, the Jenny Craig diet, the even potentially the keto diet, and for people early on works very well, but even just a restricted diet might work well. The eating disorder paradigm, their take, which is in sharp contrast to I think both of the other two, is let's eat moderately of everything, and stop with the restricted type of behavior, because that will just that's a sign of pathology. And then there's this piece here which I want to of course talk about. So here are some of the 20 questions. Have you ever stopped wanting to eat and found that you couldn't? You think about food constantly. There's the obsession. Do you binge and try to get rid of it? Do you eat differently in private? You could ask these questions of alcohol as well. Do you eat large quantities at one time? very hard to distinguish between binge eating disorder, and this is, like I said earlier, a big problem with getting food addiction acknowledged. Very hard. How do we know the difference? Because the research that has been done looking at the ways to determine what a binge eating disorder looks like. It looks like this. All you need is 3 of these criteria, and you fulfill the criteria. So you can often be, it's highly, highly sensitive to both conditions, but very nonspecific. Very nonspecific. How do we know? Basically, it's through history. If you've tried to restrict and found that, if you've tried to moderate and found that it didn't work, try food addiction. But just so you're aware, there is something called the Yale Food Addiction Scale that does try to measure this, and this has been used and peer-reviewed, and it's quite useful. However, it is not that specific. How do we, do I have a slide here? Yeah. How do we know how many people are food addicted? In the obese population, generally the number that we're saying is 37 to 40%. Which, by the way, for people who are naysayers and say that this doesn't exist, you may well be looking at a clientele, your clientele, that are not food addicts, that Jenny Craig and various diets do work with moderate amounts of chocolate or a little bit of dessert. It may well work. But there is a small subsection of the population, anywhere from 6% in the normal weight, actually underweight. Remember, I was talking about anorexia, a little bit higher in the overweight, and the obese population much higher. So 40%, some people say as much as 60%. To tell you the truth, we can't really measure it until we acknowledge the condition of food addiction, which we haven't done yet, so it's very hard to measure. Okay. So different stages, if we see this as an entity like any other addiction, there are different various stages of early stage, which may look like a normal person or an eating disorder, and all the way to later stages, eating disorder, food addiction, final stage where it fulfills all those criteria of food addiction. And it's the later stages that we often see in our clinics. You all have seen this treatment paradigm. All I want to say is that it's not useful. Surgery is not going to make any difference. I'm starting to see, and then there's pharmacotherapy and lifestyle, which is diet. We are already seeing that there is a bariatric failure, or maybe not failure because the person still has maintained a fair amount of weight loss, but they regain. There is weight regain, and it's certainly enough to be distressing for people. And why is that? Because they are probably eating foods that are derailing their otherwise good food plan. I don't want to spend more time on this, but I do want to say this: not there is also a phenomena that's happened where there's a higher rate of alcoholism just because of the bariatric surgery itself, which is interesting, because if that's happening with alcohol, so anywhere from pre-surgery 7% up to 11% post-surgery, if that's happening with alcohol, why wouldn't it be happening with food too? A person may have been able to get away with having a piece of cake once in a while, or even a lot, but then could stop, but post-surgery are not able to do that anymore. So this is just in the line with the treatments that are being offered that don't really help with food addiction. You know these drugs. This is appetite suppressants for obesity, and the hormone-based drugs, not really touching the concept of. The only one really that might help with food addiction is Contrave, which is buprenorphine and naltrexone, but I've not seen enough success with that. Quite frankly, the most successful is, just to show you again, if we look at this specifically and connect the dots, the obvious dots, which are to get rid of the trigger foods. If you're following the normal diet that's suggested, it'll be moderate foods, which works with basically earlier stages of food addiction and any other condition that a person may have. These things may work, but it doesn't work for later stages. It does not work. And my sense is that if a person's already coming in for treatment, either bariatric surgery or metabolic syndrome, they're probably already in the mid to later stages. And then the best solution there is abstinence of the trigger food. This is my bottom line. message that I want to make, that there is enough evidence with this food addiction model, sugar addiction first, that just quitting the substance itself, don't let the thing get kindled, don't let the calibration of neurochemistry, the dependence, recalibrate itself so that you don't desire the sugar. The good news is, like with any other addiction, including cocaine, crystal meth, alcohol, if you stop, cessate, I don't mean moderate, you're going to go in withdrawal, yes, but it will only last 3 to 4 weeks or even less. That's with all of those substances. Yes, there's a residual withdrawal. It's actually longer than that, but the worst of it, 70% of it, is just in that first month. Get over that, and you're going to notice you'll feel a lot better. If you, however, do moderate, you're just prolonging. It's like somebody who quit smoking and they're trying to cut down. It's just prolonging the agony of withdrawal into months. It's just easier to just stop and get through the first few days. If you are in a later stage, I'm coming to the end here, if you're at a later stage of food addiction, so that it's not just sugar and refined starches, it may actually now include grains, which also on the glycemic index are, fairly high. It may include dairy, it may include artificial sweeteners, all these drivers of dopamine with the amount of carbohydrate. Is it quick? Is it a lot? A person becomes more sensitized over time, like that kindling piece, that it may well be, and we know addiction is chronic and progressive, that these things you may have been able to get away with them earlier on, but you can't now. If you're far enough along the line, your ability to remember, we've got this denial piece, this ability to dismiss. There are some people who will actually advocate to weigh and measure their food because they can no longer eyeball, because 2 looks like 1, a certain amount of like a tablespoon of you might say, I'm just going to have a tablespoon of almond butter, and it's actually, to somebody else's eyes, it's actually 4 tablespoons, but it looks like 1 to you. So weighing and measuring is a way of taking it out of control. And then you've got this whole tool of addiction tools, like, for example, out of sight, out of mind. Get support, get help. The concept of surrendering your choice because you no longer have any. Okay, so that's food addiction. I want to say something about intermittent fasting because I know that's such a craze right now, and it's something that worries me a great deal for food addiction, end-stage food addiction, not for other people. I certainly understand the science behind metabolic syndrome and the attempt to regulate in a quick way and whatnot. But for a food addict, it could be a problem. First of all, if you actually are dealing with an eating disorder, the restrictive, you just initiate the restrictive pattern, and that's not good. But frankly, I'm more interested in the food addicts. What you're going to do with the hungrier you are, the more the dopamine is increased, and it becomes a gateway then to eating sugar or another drug. We have this is one of the tools in the addiction paradigm: hungry, angry, lonely, tired. If you're hungry and angry, which happens, it's called hanger. Hangry. If you're tired because of it, that's already 3 of the 4, and you're going to just have a super binge. And I think that for somebody who has food addiction, they should be very careful with intermittent fast. It should be a medical intervention done with a doctor, not just to be done on the internet with a coach. No, I really strongly feel about that. So if it does need to be done, it needs to be done with a great deal of caution. I think that's pretty much all I want to say there. So I think that's it. This is just my little spiel. I've covered the hormonal, endocrine, neurochemical drivers of satiety. That's the leptin, ghrelin, insulin, dopamine connection. I've identified the disorders that can happen, basically addiction. Discussed the clinical syndrome of food addiction, which is that entity that has developed outside of now the foods. There's more to say about that, but I don't think I have time to say that. I can say that another time, or if someone has the question. And then the differentiation of food addiction from eating disorder, very hard to do, except at the end. did restriction work, then or cessation of a trigger food, then it's food addiction. If it didn't work and threw you back into more trouble, then it's an eating disorder. Unfortunately, the treatment determines the diagnosis at this point in time. And then the addiction model of treatment of food addiction, I hope I have covered sufficiently. So hopefully I have convinced you all about this condition. If you want more information, there's my book, there's my website called Addiction Unplugged, and I have a Facebook group called I'm Sweet Enough, Sugar-Free for Life for you to send patients or yourself to. And by the way, I belong to something called the Food Addiction Institute in the US, and we actually developed a flyer for family doctors to introduce the concept of food addiction, which you can get if you get these slides. You can't see it here, but, oh, it's down here. Well, anyway, there's a website down there. And it has a flyer that you give the person, that poster, and basically more flyers, more information, so you can actually give something to your patients. And that's it. That's me.